Show and Doc Tales with our host, Rural Doc Alan Lindemann. Doc, what's going on, man? How are you?
We're doing really well here, Neil, and you and
Fantastic.
Pete.
Yes.
Nice to be here.
Yes. Who is our guest today, Doc?
Yeah, Kia Parsi.
All right.
Dr. Parsi.
Doctor. Yes. Thanks for stopping by. I think your connection's amazing because of the rural aspect. Kind of go into specifically your background, Dr. Parsi, and how you got started in medicine and what you do now.
Sure, sure. Well, I always wanted to be a family physician in a small town. So after medical school and residency, I worked in a small community, about 3,500 folks, and full spectrum family medicine. Did that for about 20 years and then went into administration. And now, since November 22, I am the executive director of the Texas A&M Rural and Community Health Institute. We're trying to support rural healthcare institutions in Texas and across the country to make sure that they provide high quality, accessible healthcare.
Good, Doc.
Well, certainly we need that. And, in North Dakota, we started doing this about in the late 70s or probably early 70s. And of course, I told you on LinkedIn, I was the director for the family practice residency OB program for 1/4 of the state of North Dakota. And so, we spent a lot of time training our young doctors to do obstetrics in rural North Dakota. But that's just part of it. That's just part of the problem. And what do you see as
Right.
some of the main problems with getting into rural, our low access areas?
Right, right. Well, there's a lot of challenges with rural healthcare. There are several issues. One of it is reimbursement. A lot of rural communities are mainly uh, individuals that have insurance through government agencies, Medicare, Medicaid, and uninsured. Depending upon your state, if there was not Medicaid expansion, a large percentage of people living in rural areas have no health insurance. So that makes it tough to have viable healthcare institutions. And specifically with maternal care, because you talked about obstetrics, because these populations are small populations, how do you provide enough exposure and experience over time to keep trained staff that continue to have their skills to provide the appropriate care that they need to?
No doubt. It's like the problem you said is not many people were insured in rural areas. Are you seeing that in same in impoverished areas and cities too? What's the correlation between rural healthcare
Sure. Yeah.
and inner city healthcare? Where there's lots of poverty.
Yeah. There's a lot of similarities. Often food deserts where you don't have good access to food, of adequate transportation, and lack of providers. Just like in rural areas, a lot of urban areas that don't have all the resources, you don't also have physicians and advanced practitioners working in those communities. So there are definitely similarities between urban areas with limited social determinants of health challenges and rural areas.
Well, you're right. There's a lot of access problems is really what you're looking at. What
Yeah.
do you see as I'm sure you're aware of the fact that in the United States, our maternal mortality rate is not very good. We rank
Right.
36 out of 36. What do you think is happening with that?
Yeah, it's a question that a lot of people are scratching their heads about because our healthcare is not cheap. And what's especially challenging is with certain ethnic groups, African Americans, Native Americans, to some extent Hispanic as well. They have the poorest outcomes and significantly affected, especially African American. African American in rural is probably the worst outcomes, worse than some third world countries. A big part of it's access, limited access to healthcare, inappropriate access, There are some issues culturally as far as comfort level. You know, people like to see healthcare practitioners that are like them, and we have a dearth of uh, primary care and other specialty physicians that uh, look like many of our minorities.
Yes, you're right. But I've read a little bit that sometimes even doctors of color have trouble with patients of color. They think they're going to
Yeah,
get a better
sure.
care, but they don't really get better care.
Well, and I think, you know, you can make generalities, of course, but I think there are definitely challenges for minorities to get care that they feel comfortable with.
Right. And in rural areas, rural communities, especially in Texas, what is the demographic usually
Yeah,
compared to, let's say, rural, inner city? Yeah.
yeah. You know, Texas is a big state, so along the border, heavy Hispanic
Uh,
populations, 80-90% Hispanic. There are certain areas of Texas that have larger African American communities than others. Texas also has some big cities. Houston is one of the most international cities in the country. Dallas has grown as far as its diversity. So Texas, you know, it's such a huge state. You almost have to look at different regions as far as the different demographics.
okay.
Yeah.
But
So yeah, go ahead. Go ahead.
I have a little story here. Like I said, I trained doctors for years, for almost 20 years, but that was just a part of it. That was, and yes, I think you can get doctors to commit to a small community. I certainly did. I tried it. That was what I've done at the end of my career. And I certainly knew how to do obstetrics. I can tell you that. I've delivered
Right.
about 6,000 babies with no maternal mortality, so I know how to do it. And I went to a small town. I talked with the CEO. I talked with the board, the head nurse, the head OB nurse. Everybody was on board. So the CEO said, if you come here in May, I'll have an anesthesiologist or an anesthetist here in August. Well, when I got there in June, he was gone, been completely replaced by
Yeah.
somebody who didn't have a clue as to what we had discussed. What I didn't realize was that there was a whole nother layer of board on top of him, on top of that board that made all the
Yeah.
decisions. You really have to have the community support, and every single board and every layer of every board, every CEO, every nurse needs to be on board with that. And one thing we didn't do when I was in my, providing all this service to the UND for these student residents, we didn't think about this. We didn't think about what it was like for the young doctors to go to the communities and practice there.
Do you agree, Doc?
It's not easy. Can you all hear me?
Yes.
Yeah. So rural healthcare has so many challenges. We talked about the financial challenges. We talked about the difficulty to keep your skills up. Rural hospitals typically have turnover, a lot of turnover. An administrator, I'll tell you, the average lifespan for a CEO for a large healthcare institution is 4 years. It may be half of that in rural communities,
Wow.
and often you don't have, yeah, you don't have highly skilled individuals, and healthcare is not easy. Healthcare finance is especially challenging. So that just confounds the challenges that you have in rural communities to have healthcare that's sustainable, but also, as Dr. Lindemann mentioned, the stability that you need to grow programs.
What do you think this is going to be needed, especially you're in the symposium and you're speaking about this to
Yeah.
change the narrative for rural healthcare?
Oof. Yeah. If I had a magic wand, definitely some way of creating some payer payer equality. See, part of the challenge with with healthcare, and we saw this with COVID. If you remember, there was a period of time where hospitals closed down their operating rooms because of COVID. Well, operating rooms are the profit revenue generator for most hospitals. Rural hospitals don't have operating rooms. They're just providing care for patients that need medical care and often don't have the high payment procedure-based revenue that you see in urban hospitals. So you would need some kind of a payer strategy that ensured that rural hospitals got the reimbursement they needed to stay open. And there has been work on that. There's a designation called critical access
Yep.
hospital designation that was created many years ago, and that affected Medicare payments. Now with Medicare Advantage, that has sort of eliminated that payment structure. So often there are unexpected consequences with different types of healthcare strategies, and often rural communities are not considered.
Okay. Wow. I mean, that magic wand, Doc. And you were
Yeah,
Doc, you were mentioning in one of your articles, right? Rural Doc Allen was about the need for involving the issues with rural women with pregnancy, right, Doc?
Yes, there's many things. I think you were talking, uh, Kia, about healthcare discrepancies as far as payment goes. And, Medicare has different payments depending on what state you're in. In North Dakota,
yeah,
48 out of 50. We do have among the best results in the nation as far as our Medicare outcomes, but we are paid. There are 47 states that are paid more than we are for Medicare services. So that's a
yeah,
problem. Another problem that could be resolved is med mal. In other words, you could, for
yeah.
example, you can't sue the government for med mal. You can't sue a VA, at least not very easily. So you could do things like that for rural healthcare, and that would just take the stroke of a governor's
Right.
pen, president's pen to do that. So there are things that could be done quickly, and could be done easily, but they would have to be done.
Right. And rural areas, Medicare reimbursement may be different than urban areas. And then there's Medicaid, which are, it's part federal dollars, but they're all administered on a state basis. Some states expanded Medicaid, others did not. And how states fund the Medicaid systems are very unique to each state as well.
Texas
Well,
a lot different than, let's say, a Northeast state, right? When it comes to Medicaid and who qualifies.
Right. I mean, each state creates their own with some restrictions and some guidelines, but each state has their own requirements, their own structure, their own payment schedule. Yep.
Um,
Yep.
Quite interesting. So, people, what is your goal for the new position you have about the rural healthcare system with tech? What is your goal?
Yeah. We have two main focuses. One is workforce. How do we encourage the next generation of healthcare providers to consider rural? So we work with the Texas A&M School of Medicine, School of Nursing to try to encourage students to think about rural as an option, as well as pharmacy students, even veterinary medicine students. Vet med is important in rural areas. So we try to encourage them by giving them opportunities and exposure in rural settings. There's a lot of advantages to living in a rural area. You know your community. You can feel the mission when you're part of a rural community. Often your commute. Uh, when I was working in a rural area, if I hit the site, it was 8 to work. So compared to live in an area where you have to drive half an hour or an hour to work, so
Cost of
there's
housing
definitely
too.
advantages to living in rural areas. Yeah,
Cost of
exactly. Yeah,
housing
we
too.
want the students to have that exposure.
Mhm. That's
Yep,
great.
for sure.
All right.
Yeah. So that's one. And in addition to workforce, then the viability. Make sure that these institutions can stay open.
Okay. All right. Is there a place we can find information on you and what you're doing?
Yeah, sure. We have a website. The name of my organization is the Texas A&M Rural and Community Health Institute, Archie for short, RCHI. And yeah, we're working. We right now have some state funds where we're trying to support Texas hospitals and clinics all across the state.
All right. That was the special simulcast of the Neil Haley Show and the Doc Tales podcast, guys. Take care.